It's my pleasure to introduce this evening's speaker in our series, our professorial lecture series. Professor Rosemary Richardson is going to speak to us this evening on a topic called Patient Heal Thyself. Rosemary is, of course, an honorary professor with Queen Margaret University. We only give honorary professorships to very distinguished individuals within specific fields. We offer them an honorary chair, they accept, and then we tell them that they have to give a public lecture. It's a little cruel, but we have to give our fun somehow. This particular lecture epitomizes Queen Margaret University, because at Queen Margaret University we firmly believe that all of our education and research should be relevant, should have impact on people's lives. And what Rosemary is going to talk about is work that has a significant impact on clinical practice and by dint of that on individual patients. So we're absolutely delighted that she has accepted our invitation to be an honorary professor and to give this lecture this evening. We're very proud of Rosemary because not only is she one of ours in terms of being a former employee, she's also one of our graduates and indeed was part of the second cohort of dietetic students at our old Kirstorfen campus. We're also very pleased that she has kept in touch with us and has maintained her research links, particularly working with Professor Isabel Davidson since her move across to the West. Particularly culminating in the recent grant from the Macmillan Cancer Care. So Rosemary is practice development lead for dietetics in Greater Glasgow Health Board, based at the Southern General Hospital. In 2010, she received the prestigious Macmillan Cancer Care Education Award. She is a regular invited speaker at prestigious national and international events, including the very prestigious Elsie Woodison Lecture in 2010. She has attracted research grant funding over her research career of over £1.5 million. She's very active professionally in a whole host of groups and committees that I do not intend to attempt to cover, but she is making a significant contribution to the discipline and the profession of dietetics. Outside of work, Rosemary is a keen golfer, but needs to work much, much harder on her handicap. It was written by Isabel. Ladies and gentlemen, you've not been here to listen to me. It is my great pleasure to introduce Professor Rosemary Richardson.
Thank you. Can you hear me at the back all right, Gillian? You're okay? Because Professor Davidson said she'd very willingly swap with anybody at the back who couldn't hear. But that's great. I'm so glad you can hear. Thank you very much, Professor Galoran, for that very generous and kind introduction. And of course, when I was invited to speak here at Queen Margaret University, it cast my mind back to when I was a young undergraduate and very enthusiastic student. And here's a picture from the old campus, and I see there are some undergraduates, postgraduates here this evening, and this, of course, is where I worked extremely hard, occasionally, and I then took up my first post in Belfast. I thought it was a cat's pyjamas. I'm in Belfast at the height of the Troubles, and then for a quieter life went on to work in Saudi Arabia, and then back to Scotland and to, first of all, the Glasgow Royal Infirmary, then Edinburgh Royal Infirmary, where I worked in departments of surgery and biochemistry, before joining dietetics once again and coming to Queen Margaret University as a lecturer, and then back to Glasgow, where I'm in Glasgow Health Board. Unfortunately, I don't have any more up-to-date pictures. Anyway, first of all, my title of the presentation this evening is Patient Heal Thyself. And I thought at the time when I was asked to give this talk that that was a relatively attractive title. You see, I come from a relatively small family, and it was important in a lecture theatre like this that you were able to put some increased numbers. So that was the title. But it's only when you come to sit down and put your talk together that you realise you were on hallucinogenic drugs when you put that title together. In actual fact, the title of my talk should have been Patient Treat Thyself rather than Patient Heal Thyself. Because really the focus of my talk this evening, it will be about patients with long-term conditions, where a patient's life is irreversibly changed. And in long-term conditions, our goal cannot be cure, but what we want is maintenance of a pleasurable and independent living. In Scotland at the moment, about 2 million people have long-term conditions. As we know, our health service, free at the point of care, our great treasure, was started on the day of my father's birthday, the 5th of July, a little bit later, 1948. But that health service was designed around acute care. And of course, a very, very, very long time later, I joined the health service too, once again in Northern Ireland. And at that time, patients were passive recipients of medical care. There's Leslie nodding with a nursing background there, but it's true. They were. We told the patient what to do, and we had great faith that our patients would go off and do it. It was not questionable that patients wouldn't do it. And I remember, even as a student of the time, that doctors would stand at the bottom of a patient's bed, talk about the patient as if they weren't there. So very much passive recipients of care. Well, as I've said, the healthcare system that we have is developed around acute disease, and unfortunately our practices have proved inefficient and ineffective. But we've been doing a lot of work in recent years to try and improve our efficiency and effectiveness. And the resources that we have and will continue to have are unable to keep pace with demand. So in essence, the challenges that the NHS of today and tomorrow faces are threefold. Firstly, in terms of our population. If you think of the Scottish population at the turn of the century, it was shaped a bit like a pyramid. We had fewer younger people, we had fewer older people at the top, and plenty younger people to look after the older people at the top. Now that pyramid's become inverted, with many more older people at the top and fewer younger people to look after. So I'm a bit worried about that. And perhaps it's contextualised when we look historically. For example, George V in 1917 congratulated only 24 centenarians. And now that's a difficult word to say when you're up here. But Queen Elizabeth II, shortly after she came to the throne in 1952, congratulated 200 people over the age of 100. But by 2007, that had increased to 4,600. But fortunately, Wolls is right on the case here, bulk buying his telegrams, because in 2031, over 40,000 people will be congratulated. So that gives you an idea of the increase in our ageing population. From 2004 to 2031, there will be a 75% increase in the number of people over the age of 75, and I hope I'm one of them. So as we age, of course, we're more likely to place demands on our healthcare resources. And here are some examples of long-term conditions. Things like diabetes, obesity, cancer, and other conditions. And the numbers beside them are the number of patients that we currently have in Scotland with these conditions. So for diabetes, we have over 250,000 people in Scotland with diabetes and over 153,000 people with cancer. So that gives you some idea of this challenge that faces the NHS. Because these long-term conditions take up about 70% of the hospital budgets, whether it be primary care or acute care. And if you look at their demographic details, that is likely to increase. Two-thirds of people over 65 have at least one long-term condition. So that's one challenge that we face. The second challenge is perhaps the advances in medicine that quite rightly we want to embrace. For example, every year there are new drugs on the market, but we also ask our questions, can we afford them? And that's when you see organisations like the National Institute for Clinical Excellence intervene. The National Institute for Clinical Excellence will decide on the efficacy of a drug and sanction its prescription. We also have improvements in imaging techniques, things like CT scans, MRI scanners, Very expensive and cost millions of pounds, yet the use of these scanners improves diagnostics and improves treatment. The improvements in surgery and of course realising research such as stem cell research or genetic research are all things that we want to have in the health service of the future. But can we afford it? Because there never has been enough resources in the health service. But I haven't seen anything like the permafrost that we have now. There is little or no money in the system, and yet we have to face these challenges. Things look very bleak. But fortunately, there is light. There is light at the end of that tunnel. And what is that light? It's the Scottish Government Health Department. And so it is the Scottish Government's Health Department responsibility to give us strategy and policy to help us meet these challenges, these very real challenges that we face. And there are two documents that they've recently come up with. There's Better Health, Better Care and the Healthcare Quality Strategy that are the current documents that will dig us out of this hole. I'm over-exaggerating. But these documents are different in that the patient is at the centre of care. No longer passive, they've become much more in the centre of what we do. And how do these policies work? Well, of course, Nicola Sturgeon will go on and give you all the PR and all the rest of it. But out of these policies come health department actions. Oh, I shouldn't have touched that, sorry. Health department actions. And from these health department actions comes something called HEAT targets. Liz saying, yeah, I know some people here from the health service. And HEAT stands for Health Efficiency Access Targets. But a HEAT target that everybody I should think here will be familiar with, for example, would be waiting list times. So something like 12 weeks is it 12 weeks now? From referral to treatment. So there are lots, a whole host of these HEAT targets that boards are told you must meet these HEAT targets. And the board then comes on to all the services like Fiona Clark and dietetics and said, there's your HEAT target list, get on with it, and then report back. Surgery, medicine, all of them will get their HEAT targets, and that information is then fed back to the Scottish Government. What does that actually mean for us foot soldiers on the ground? And so to tell you what that means, I have to take you to Glasgow where I work. And you can see it's a quiet, tranquil city in the west, accounting for about a quarter of Scotland's population. I and Fiona Clark, who's in the audience today, and several others, come from the acute division in Glasgow. So that means we look after the hospital sector in Glasgow. There are 6 hospitals in Glasgow, 4 north of the river and 2 south of the river. So it's north of the river, we've got the Royal Infirmary, Garton Naval, the Western Stob Hill, and south of the river, the Victoria Infirmary and the Southern General. So in total about 3,000 beds. And of course, I said, I come from a dietetic service. And of course, going back to student days, I didn't really know what dietetics was when I started here. And when I went to discos and things, neither did anybody I danced with know what dietetics was. So I thought it was a fairly safe bet maybe to explain a little about what dietetics is. And in broad terms, it's about the manipulation of metabolism and disease, about nutritional intervention where patients' condition may have caused them not to be able to eat properly, have developed malnutrition, and we look at feeding patients orally, we look at feeding patients through tubes, through veins, and also look at nutrition education. We want to engender behavioural change. So how then, let's go back to these policies, how are we responding to these policy drivers? Now I'm just going to take a few minutes to tell you how we are, and for us, our guiding stars have been 2 models perhaps. The first is called the Wagner Care Model, and this model has been advocated in Europe, in North America, in England, and also in Scotland. It's in Better Health, Better Care. And this is talking about looking at the delivery systems that you have and improving the efficiency of them, effectiveness of them, to develop improved outcomes. Here we are, improved outcomes there. So for example, you can see a list here like clinical information systems, so that's all your IT systems. Your delivery system design might be your outpatient appointments, your scheduling. Your decision support is your evidence base that you have for your practice, and then self-management. So we want our patients to self-manage. I'm going to come on and talk about that a bit more. And again, to make these improvements happen, We also need to have a prepared, proactive practice team ourselves and the informed, activated patient. So very different from that passive patient, productive relationship between the two. This is an evidence-based model, and you don't need to introduce changes to all of it at one time. The other model that we kind of the other model that we look at is called the Kaiser model, from the Kaiser Permanente Institute in the States. So in the future, we've got this big demographic population, very little money. Now what we're saying is that 80% of patients with long-term conditions should be self-managed or supported self-care. And the remaining 20% will be high risk and highly complex. So our healthcare professionals will deal predominantly with that group. Now that's a huge number of patients requiring support and self-care, and a long way for us to go. If we take some other elements, I'm going to take a couple of seconds just to say what we've been about in terms of that Wagner model. We've been doing a lot of work looking at the productivity and efficiency of our service. For example, our outpatients. Is the dietetic service providing an efficient service there? Is the resource being used? The dietitian's not sitting there doing our knitting, for example. And if that happened, then they get moved to another area. I've exaggerated and made light of it. But in essence, we're making sure that the clinics are used appropriately. And also qualitatively examining what happens at consultation. So if you're diabetic and you're treated at Garton Naval, you can be assured that the same would happen to you if you're treated at Stob Hill. So looking at actually what happens. We're also, quite an exciting event for us, is that we're moving to having electronic records. So no longer do we have to write on paper, but these will all be stored electronically. And it will allow us much more efficiently to look back and see what we're doing. So allow us to have evidence of the effectiveness of the processes and systems that we employ. Of course, the other things we want to embrace are the advances in clinical metabolism and, most importantly, patient acceptability. The patient is much more, as I said, at the centre. Because for the first time, patients will actively decide on their treatment. They will no longer be those passive recipients of care. They are right at the centre. But to allow those patients to be actually active participants, they must understand and must be informed on actually what us healthcare professionals what journey we're trying to take them on. I could talk if I wanted about the prepared proactive team, but time precludes me speaking too much about that. I'm going to focus more on the informed activated patient. But Liz Waterhouse, who's here this evening, is doing a lot of work with us in that area, and we're linking up with Queen Margaret University, and we're doing that at the moment in renal medicine, so patients with kidney problems. So let's go back to patient treat thyself. Is it going to be the B&Q of healthcare? Are you just now then, 80% of you are going to go back and you're going to get a leaflet and told, there you are, off you go, read your leaflet? Well, I'm afraid it seems a simple solution to meet those challenges that we have in the health service, but it's not that simple. Self-management is very different, as I said, from telling patients what to do. We know that they want them to have a central role and take responsibility for their care, and we want them to become active participants in their care, and potentially getting them to lead on the decision making. Central then to that happening must be the communication that we enter into with patients. Whether it be verbal, written, electronic, it's a communication. And there we have another challenge. Because that communication is such a wide range of individuals, from your ex-shipyard worker in Govan to your bridge paying lady from Mulgai. Their needs are very different, and the potential level to understand what we're trying to say is also very different. Because here, in this slide here, you can see the father of something called health literacy. I know he doesn't look old enough to be a father, but his name is Dean Schillinger, and very fortunate, Morag, who's in the audience here, also helped organise Dean coming over a couple of years ago from California. And he has really taken this whole issue of health literacy forward and shown that can impact on patients' ability to cope with health information. And health literacy is actually, the degree is defined as the degree to which individuals are able to obtain, process and understand basic health information and services needed to make appropriate decisions. Health literacy includes being able to read instructions on prescription bottles, appointment slips, health education brochures, our instructions, and of course consent forms. It's very easy for a patient to take a wrong message from what we're trying to say. So we assume very often that patients have understood what we've said, and that may not be the case. So the impact of poor literacy, there's considerable evidence in the literature, actually shows there can be an increased risk of hospitalisation, increased number of emergency admissions. If you don't understand your medication, you're more likely to make treatment errors, but also you've got a reduced ability to self-manage. So again, you can see that this is important in us looking at patients' supported self-management for the future. So we've really began in a fairly small way in looking at self-supported self-management. And in preparing us and the patient for this agenda, we began to look at where we were starting from. And I apologise, you can see that we really started some years ago. I apologise for the quality of this slide, and I'll try and talk you through it. But it's about, do patients actually understand the advice we give? And this is a group of 30 patients approximately who'd been seen on 2 occasions by the dietitian. And we've looked at knowledge and understanding, again a fairly recognised methodology in literature. And when you look at knowledge, when we ask patients, these patients received nutritional support, so the sort of concepts that we're trying to explain were the same. Okay, so we asked the patients true-false questions around these concepts and then asked them to justify their answer. So the true-false was the knowledge, justification was the understanding. And when you look at knowledge, you think, we're doing not bad, 7 out of 10, we're okay, great, right. But when you look at understanding, it falls to 5 out of 10. Not doing so very well at all. So patients don't really understand. To give you an example, Professor Davison, who was here this evening, if I asked Professor Davison when the Battle of Hastings was, she would, I'm sure, be able to tell me 1066. So she has that knowledge. But I said, what's the political environment in which that happened? It's very unlikely. It's very unlikely she would be able to answer me that. So if we look at this study again, this was our work that we looked. These patients were seen twice by a dietitian. This is not unique to dietetics, by the way. We look in the literature, you can see exactly the same thing coming out in other areas. Almost half the patients didn't know what a dietitian was, yet we saw them twice. 60% were able to identify which part of their body their disease affected, but only 30% understood the impact of the disease on nutritional status. So this was very important. It began to make us realise that really we need to relook at the way in which we impart information. So we slowly began to get our foot on the ladder. Now, in terms of the self-supported management agenda, we have to think about who we're actually going to target. And, you can go away and start to say a group of patients or whatever, but by chance, really at that time, at the Beats and West Scotland Cancer Centre, we in dietetics had a very low number of staff. The centre opened in 2008, and it's the largest cancer centre in the UK, Marsden and then us. We have about 8,000 new patients a year. We deliver 14,000 courses of chemotherapy, 6,000 radiotherapy, and about half to 3/4 of these patients will suffer from malnutrition. And Helen, you're going to see you're here this evening. I dealt with a lot with cancer patients. I know that the effects of nutrition can be fairly devastating on patients and their family. So we had that very limited dietetic resource, and yet we had all these patients out there. So how then, and that's not going to change. Fortunately now we have Caroline McAteer at the helm there who's steering that steady ship. But we began to look at how we might be able to cope with that in terms of beginning to embrace that self-management agenda. And this is our idea, and I'm delighted to say Macmillan will support us in taking this forward. We've already done some pilot work, but we have developed, better touch it, interactive resources, and we will use people affected by cancer, they call it now, to become Macmillan supporters. And these Macmillan supporters who've all had cancer and been affected by cancer will support patients going through the cancer journey. It will be in topic specific. So at the moment we're working in the area of nutrition because that's obviously the area I'm in, but we're looking at other areas, and it's likely that the next area that will come on board will be concomitant chemo and radiotherapy. Results are excellent of that, but again, patients have a lot of complications. It's important that our supporters are supported by professionals, so that's why we're there, and also that the whole scheme is properly risk managed, so that, for example, you don't get somebody who's gone through the interview process who is slightly alternative and says, if you rub avocados into your skin, you won't need to have your chemotherapy. So we want to make sure that we have systems in place to be able to do that. Now, beginning to engage in the self-management agenda takes up a huge amount of time in beginning to develop it, and of course a resource. So that's where we're very fortunate, again, in working with Macmillan and with Queen Margaret College. University, sorry. So at the member at the top, I said you want to develop resources, interactive resources, because your supporter needs something that they communicate to the patient with. So we decided what we wanted to think, what do patients need to know with cancer? We only wanted to focus on a few concepts because clearly patients can only take in 2 or 3 concepts at any one time, and we didn't want to reinvent the wheel, so we had a look at what was already out there. We started to run some focus groups, which I thought, until I'd worked at the university here, were actually quite rubbishy. You know, I was really more into quantitative research. Extremely rich, extremely rewarding. And when we ran these focus groups, our cancer patients viewed nutrition as being important. But one thing that came out of our groups universally was that patients wanted to understand. They felt a lot of the information they got from healthcare professionals they couldn't understand. And I remember one lady saying to me, she came home after receiving news she had cancer. She'd seen umpteen health professionals. She came home with a whole pile, booklets, leaflets, all the rest, sat down, and she just went, put it all in the bin. She said it was too much for her to take in. But here's one that was fairly common. You definitely get good information from newspapers. You can't guarantee it's accurate, but you can understand it. Whereas information from health people, you cannot. And that came up again and again and again. So with our resource, we brought in journalists to help us write the materials. So we had somebody from Sunday Post and Herald. So we're covering the shipyards and the Mulgai ladies. And most of the information you take in is from each other. That's the information that stays. So our idea around these supporters, we think, is hopefully on the right track. So off we went and began to develop segments of this leaflet. And we wanted to get patients' opinions, whether it was appropriate, whether the information got was right. Now, there's a technique you can use called World Cafe, right? And people write on tablecloths and all this, but we thought, that's too posh for Glasgow. We have tea. In Glasgow, that's okay for Edinburgh, but in Glasgow we have tea time chat. And so we gave patients our ideas and thoughts and they wrote on tablecloths what they think of it, and then they swapped around places. It worked really well, really well. I was scared stiff because I'd never done it before. And it did work extremely well. And I remember we had a patient who came in, or a person who'd been affected by cancer, and he obviously felt very self-conscious being there. He'd ironed his shell suit specially to come along to that. And he came in, didn't say a word, and then suddenly he felt comfortable, and his information he gave us was so rich and really so very useful. So really, we've done a lot of work looking at the text, the artwork, the layout. I won't go into this too much. Writing style is very important, because I don't know if you've read health information leaflets, you start to go, oh. But you really want to feel as if somebody's there with you and that you have to participate with it. And again, illustrations and concepts. So here you see, here is our resource. And you can see, again, thanks to Christian Russell, who's here, who's been significant in making this happen, it's lively, it's bright, it's colourful. The patients themselves chose it. It wasn't us. Patients chose it. Then you can see the information inside. Patients have to tick boxes. So here we are. Since diagnosis, do you think your relationship with food, anything has changed? So they begin to write down what they feel and tick boxes, and they can take that back and talk to their supporter about what they've written down and that. Another thing, our anatomical diagram here of the gastrointestinal tract, we thought, oh, patients will want that. Overwhelmingly wanted it. they could begin to identify where their cancer was and what was happening to them. Again, we also tried to get over some fairly complex concepts. And on this slide here, I don't really want you to pay much attention to it, but it is about the effects of inflammation, which occurs because of cancer, on our ability to eat normally. So in cancer, it will cause chemicals to be released that will make your nerves much more sensitive. So for example, Jim, I haven't explained that very well, but for example, now John Wright, who's here this evening, I think is a man whose appetite cannot be matched at all. But I don't know, he may go to dinner tonight, and you can see he'll go in and say, I could eat 2 puddings, you know. So he starts off with his main course, eats really quickly. Starter, main course, big main course, huge number of chips. Then he has a steamed pudding, and he orders a second dessert. By the time the second dessert comes, 2 or 3 spoonfuls, and you can see he's struggling. And what's happened there is, the second pudding, his stomach distends, the nerve from the stomach to the brain fires up a signal to say, eat any more, you greedy pig, and you will be sick. But in cancer, that nerve becomes sensitized, so that people with cancer may just take soup, and the nerve fires off the brain and say, don't eat any more. So that's why you see in cancer very often they feel under a lot of pressure from relatives to take food and eat food, but physically the patient feels that they can't. So we've got this story, just using that same example that I gave you about John Wright over to the patient around that, and they could begin to understand that. Acceptability of the resource, I won't read too much. I'll leave you to read that yourselves, but you can see it did achieve what we wanted to, that people would pick up again and again, that it got people involved, and that writing down helped them understand. And these were things that we wanted to happen. I won't read this one out because this is a bit embarrassing, but Fiona White from Glasgow University also sent this note to the Minister of Health, Nicola Sturgeon at the time, to say how impressed they were with that leaflet and our new approach. And as far as I'm aware, this is the first time this approach has been used with patients. So we hope to go on and do more of this work, but we still have a long way to go. It is quite costly. That leaflet costs a lot of money in terms of development of it, and it would be unfortunate to leave it just isolated to Glasgow. We have to begin to realise the benefits of that and go about that. So we've looked at the acceptability of the resource, fair enough, but what actions were employed by the patient that allowed that patient to be self-managed and reduce time on healthcare resources is what we still have to look at. For our Macmillan supporters, we've got the resource, now our Macmillan supporters who come forward, and we've got a small core of Macmillan supporters who volunteered, but soon we're going to be rolling it out. And has anybody eaten in McDonald's? I don't think so, but if anybody has eaten in McDonald's, have you ever been in, and they have little badges with little stars on it? Yeah, I've been once, I remember. And what our vision is that our Macmillan supporters will undergo training in a core area. We've already developed that around communication, and then they will have topic specific. So they may have their core, then they might have nutrition, then they might have concomitant radiochemotherapy, benefits, so the list can be endless. But one thing is, these supporters gain confidence. That was a big thing for the people affected by cancer. They said that they began to get some of their confidence back. But what's also important is that other healthcare professionals feel confident with the supporters. Because, they might say, I don't know if I can have that, that's just patients telling patients. But if we have some form of accreditation, then they're more likely to have confidence in those individuals. Also, we want to make sure that we risk manage it, and the system of operation for it becomes quite huge, and we're going to have to be careful about the management of that. So that we've got a registry of people who are Macmillan supporters, making sure these people are not Macmillan supporters for too long, so that it's time expired, matching our supporters. So, for example, we want to match perhaps by cancer site, and again, by not social class, but that kind of thing, to support that community. What we don't want to do is reinvent the wheel. And we're always looking out to see what's already being in this area, what work's been done. And there are several things. There's the expert patient programme in England, Peers for Support in Australia and America, But one thing, a lot of systems have been up and running, and a big problem for them, or the collapse of them, is they haven't been appropriately risk managed. We also need clinical trials that show us that employing self-management actually imparts benefit, because there's a cost at one end and you want to see a benefit at the other. Now, I think the most advanced whole system centre is in the States. It's at Stanford. It's not just the Patient Education Centre, it's a whole section in Stanford University in California, which is around self-supported management, looking at the patient side and at the practitioner side. But in terms of the Patient Education Centre, they've done a lot of work and looking at long-term conditions. For example, they've now looked over 1,000 patients and compared their 1,000 patients self-managed versus controls. The self-managed group had fewer days in hospital, a trend for less outpatient appointments, and a cost saving of 1.4, and was shown to be sustainable. Those are the kind of figures that will attract funding to sustain self-management in our health service, because it will bring about longer-term savings. So we have that model that I showed you around Macmillan, and for us, Liz, you'll really like that slide, David, you can't. For us, the proof of the pudding will be in the eating. In other words, can we prove that the model that we have works? We want to look at the impact of acting as a supporter, the impact of supporters on patients, and the economic cost of the model, looking at a clinical trial and benefit impact analysis. To give you an example of the kind of trial that we'll do, here's one on inflammatory bowel disease. So that's on a paper that was in the Lancet, which looked at patients with Crohn's disease or ulcerative colitis. There were 203 patients, 101 had self-management, 101 self-managed, 102 controls. And they looked at things like symptom treatment, the number of consultations the patients had, the acceptability of self-management, and quality of life. Overall, results showed that patients preferred self-management to traditional outpatient care. It facilitated early treatment of relapses. So the patient, because they understood what was happening to them, were better able to recognise symptoms at an early point. Routine follow-up was reduced by 70%, but quality of life remained unchanged in both groups. I think the latter may be actually due to numbers in their study. But still, it's very encouraging. And again, directs us as we move forward. This is a very significant project, whole systems, integrated work, and I'm very fortunate that Queen Margaret University will be supporting us in this. And also then, so how are we going to evaluate it? Well, again, guidance from other people, we just pinch other people's work. And Russell Glasgow and Dean Schillinger, who was here, have really suggested that we use RE-AIM to evaluate what we're doing. And RE-AIM stands for, R is for reach. So in other words, we'll know how many patients have esophageal cancer at the Beatson, and how many then take up the opportunity of having a Macmillan supporter. And you can then put in strategies to increase your reach. Effectiveness, looking at delivery in terms of outcomes. Adoption, participation rate of potential settings. So for example, would Stornoway take on our programme? Would Aberdeen? And also then implementation of it, but is it implemented in the way we intended? So setting up our government's manual and all the rest of it, if Aberdeen tweak it and tweak our model, it's no longer what we intended. So again, quality assurance of this model is also important. And lastly, maintenance, looking at the long-term effects and sustainability of this model. So I'm really only at the start of this very long journey, which will go on long after I've retired, I'm sure. But if realisation of benefit in self-supported management is to become a reality, we cannot work in islands. Either in islands as health boards or in small services like dietetics or physiotherapy, medicine, surgery. We must share. We must break down the barriers, break down the walls and share. I think it's important that we build mutually beneficial alliances and partnership to realise what is a shared vision, I hope. For example, traditionally in university and the NHS, the universities focus on undergraduate and postgraduate education. And in a university such as this, you wonder if that balance with a strong healthcare background will remain. There's also a strong focus on research and knowledge exchange. It should be now, not transfer. You know, you've got to have a different language when you go to university in the NHS. And then in the NHS, we're looking at extending our roles. As I said, Liz Waterhouse, who's here, is doing some work where our role, for example, will be extended into prescribing medication for renal patients. But we have to begin to link that into benefit impact analysis, begin to link that into health economics, because the NHS will only pay for additional education if it is going to be cost effective. We have to also prepare our team for self-management, and again, that's where you turn to somewhere like Stanford and again, look at the programme they have, because us practitioners, we're not really ready for the self-management agenda. And many practitioners will feel that, no, I tell the patient what to do and they do it. You know, I don't really quite trust patients to go off and do their own thing. And again, Queen Margaret University will be looking at accrediting our supporters and giving them a qualification for acting as that. There's also a whole host of work that we need to do in the resource development. So perhaps we need to think slightly differently, both the universities and the NHS, about how we work with each other. Our agendas perhaps need to converge. What I've said to you today, or this evening, I think the answer is perhaps not a magic bullet. It is going to take some time to begin to develop or begin to see real benefits of a self-management agenda. It has real potential, but we have to do it properly. This, what I've spoken about, is perhaps the tiniest of green shoots as we see that development move forward. And perhaps, who knows, people may even come back and hear Professor Davison talk. It's very unlikely, but they might come back. They might come back and hear her talk in a few years' time about how we progressed our work, because Isabel can then talk about the rewards that we might reap. I think I again thank my friend Christine Russell for this quote. When Thomas Edison had a light bulb moment some years ago, you can see that he had already thought about self-management, because he said, "The doctor of the future will give no medicine, but will interest his patient in the care of the human frame, in diet and in the cause and prevention of disease." And perhaps that's where we are now. Oh, thank you very much. And I say there are a few people on the list here that through my career I would like to thank, and many of whom are here tonight: Christine, Pat, Isabel. Thank you very much. But there are perhaps two people who are sitting in the front row that I want to give a special thank you to. And that's to my parents, who I'm very proud to say are able to be here today. Thank you very much.
Yeah. Thank you, Professor Richardson. That was an outstanding lecture this evening. 4 years ago in this room, the Chief Nurse of Scotland described the future as even bleaker for those of us of a certain age, and he said that we would be caring for one another. Perhaps he was foreseeing what you were the work you were going to be doing with Queen Margaret University. I'm wondering if your cancer supporters will one day become communities of care, where older people will live together in group settings with their cancer supporters, or perhaps they no longer have children who are able to care for them, and we will be caring for one another. What are your thoughts about creating in Scotland a caring community among those of us of a certain age? Thank you.
Yeah, I think that's a very interesting concept, and I should say I think we have to begin to publicise this work that we're already doing, and there's no reason it cannot move into any other long-term condition. But we have to dip our toe in the water, make sure it works, and who knows that I may join one of those communities in 10 years' time. Thank you.
Can I be in your community?
All right.
Anybody else?
Just off the top of my head, I thought that was an absolutely riveting lecture, and it opens up lots of ideas and possibilities. Oh, right, well, I'll just cut that bit short and say thank you for a lovely lecture. How do you propose that this can be introduced to the younger generation in a way that they're not going to perceive as threatening?
Sorry, Pat.
The younger generation of healthcare professionals.
Oh, I see what you mean. Yes.
People that are coming up that are going to have to implement.
Exactly. Well, I think that how we have to implement that is we begin to look at your top 20%, your highly complex patients. So those younger healthcare professionals need to be able to work at a higher level than we're expecting of them now. We also need them to have an appreciation of, we hope, the expert patient in inverted commas and what they can do and trust in them and utilise them as best we can. Because we're still going to have that increased number of patients to see, but there will not be the money around to employ more and more healthcare professionals. So yes, and that's why we are crying out for a similar model to Stanford in Scotland, I think. We don't have anything like that, and to begin to develop that.
First of all, Rosemary, thank you very much indeed. You've done us proud this evening, and I really do mean that. Really following on from the last question, following on from the last question, I'm interested whether you think there's any, what impact will this have on higher education? So, for example, do we need to think about preparing our students who will become the healthcare practitioners of the future in a different way?
Yes, I think probably we do, because, if you think this is policy, this is NHS policy, this is not, something we're saying that this is a road we're following. I think this policy will begin to kick in the next 3 to 5 years, and I think that it's important that we are ahead of that game. And I think the environment for our healthcare professionals working will become quite different in the next 3 to 5 years. But again, my colleague Fiona Clark, who's the clinical services manager from United, is here this evening, and I would also welcome her comments on that.
I think Rosemary's absolutely right. I think it is preparing our graduates today for the service that they're
It's going to be quite different.
Those skills to be able to deliver that kind of service, a supported self-managed service, and direct that in the coming years, because the resources that we have are limited.
Mm-hmm.
Perhaps that's something we could look at in our quinquennial reviews, because in about 5 years' time we'll have all of this information.
Right.
And we can feed it into the head of division. We can ensure that it's disseminated across the university. Do we have any other questions?
Mr. Richardson, I really enjoyed your talk. I'm not a medical person, but your topic, in a sense, patient treat thyself. Can you hear me?
Yes, I can hear you. Thank you.
Treat yourself. I read somewhere about 10 years ago, somebody in Glasgow had worked for 45 years and never had a day off work. And obviously doctors were constantly people who are ill. Mm-hmm. But can we find out from people who are well why they're well and the people aren't? I mean, in other words, this person might have a lot of illness. Maybe he was treating himself in the weekends. He never had to be off work.
That is true enough, yes. And again, it is that different genetic makeup even that may have an impact
Maybe
on
diet.
that. And it may well be diet. And again, a lot of the work that we do at the moment, and Jim Ross is gone now, looks genetically at our population. And in fact, when you look at poorer, lower social classes, the genetic makeup of those individuals over the years or generations may have been changed and has impacted that. But you're absolutely right.
This is just a practical question. In terms of self-management, I'm thinking in this case possibly an elderly person living in a remote rural location in the Highlands. How is this person likely to react to, say, an incident of diabetic ketoacidosis and be asked to manage that on their own?
It's unlikely that that's highly complex, that's high risk. So that would not be a self-management scenario really that we would be looking at.
So then can you define a self-management scenario for a person with diabetes then?
So self-management agenda for diabetes would be more around understanding of education around their diet information.
Okay. Any other questions? Oh, yes, Stella.
Thank you very much. I enjoyed that. That was very funny as well. Informative. I just wondered, have you noted, are there any trends in the type of person who wants to take up on having the supporter? You noticed?
No, because we've really only done pilot work. A lot of our time has been really developing this governance to make sure it's absolutely right in the risk management. Because unless we get that right, there's potential you could have an incident. So we're recruiting a project manager this month, I think, I hope, or whatever. And they will have a project manager and a volunteer manager, and we will really be able to move forward with a project.
Is there a question here?
Well, it's maybe slightly a bit of a comment. I work for an organisation called Parkinson's UK as well, and I noticed within the NHS and academics need to work closely together.
Yeah.
I think the key part of that is also the voluntary sector.
Absolutely, yes.
Obviously working with Macmillan,
Yes.
there's a huge amount of work being done in the self-management agenda, MS Society in Scotland.
Yes, yeah.
We work very closely with NHS Ayrshire to get people through self-management courses for people with Parkinson's. But allied to that, there is still an issue with healthcare professionals. People do manage their Parkinson's, very complex regimes, very, very well for years at a time. They then go into hospital and you can't self-medicate. No, you need your medication. No, you'll get your medication.
Exactly. Yeah.
So it is about empowering patients.
Absolutely. Yeah. And again, I think that's where I come back to Stanford once again, how wonderful they've got both sides. They've got the healthcare professional side and they've got the patient side. Because again, if you look at Macmillan Cancer Care, they've also adopted some of the Stanford programme for their self-management stuff. So thank you.
Just to finish off, I think we should thank Rosemary very much for